Good morning. We can start the presentation.
Sure, sir. Good morning, everyone. Am I audible, sir?
Yes.
So starting off, today I'll be presenting the topic TFCC, the anatomy and evaluation. I'll be presenting the contents in this order, and I'll take approximately 25 minutes of your time. Starting off with a brief introduction, Waitbreck and Henley observed the structure in about 19th century, and they defined it as a fibrocartilaginous structure interposed between the distal radioulna and the radiocarpal joint, which is triangular in shape and extending from the medial edge of the lower end of the radius and being attached to the ulnar styloid process. The term TFCC was coined in 1981 by Palmer and Werner and was classified shortly after by them. It is defined in general as a cartilaginous and ligamentous structures between the distal ulna and the ulnar carpus. It is mainly a load-bearing structure between the ulna and the carpal bones. Shock absorption and cushion for axial loading is the main function, and gliding surface is provided by the TFCC for the carpal bones and stabilizes the DRU shape. Starting off with the anatomy, it's a dome-shaped fibrous and fibrocartilaginous structure that is between the distal margin of the ulna and the medial carpal bones of the proximal row. Coming to the individual components, please focus on the figure. TFC proper is the most important and the largest structure here. This is a disc-shaped biconcave structure, triangular in shape, bordered by the dorsal radioulnar ligament and the volar radioulnar ligament. You can see the sigmoid notch here from the medial margin of the radius. You can see the medial margin being formed by the ECU tendon and its sheath and the ulnar collateral ligament. Coming to the coronal section, you can see the ligaments between the ulna and the carpal bones, the ulnar luno ligament and the ulnar triquetral ligament. You can see the structure with the biconcave disc formed by the TFC proper and its attachments to the margins of the ulna. Again, the second most important structure is the dorsal radioulnar ligament and the palmar radioulnar ligament, and the sheath of the ECU that's already mentioned, and it's completely enclosed by the capsule of the distal radioulnar joint. Same structure that you can see in the MRI view, as you can see in the structure here. The sigmoid notch, the two radioulnar ligaments attaching to the ulnar styloid, the disc-shaped TFC proper, and also the ligaments coming from the ulna to the lunate and the ulna to the triquetral. Now coming to the individual components, what is the TFC proper? It is a horizontal disc biconcave structure with its fibrocartilage center thinner at the center than in the periphery. As you can see here, it's triangular in shape, and it's a very important structure regarding the stability of the TFC and the ulnocarpal joint. It has a very broad origin from the articular cartilage at the level of the ulnar notch. It has two types of insertions. Type 1 is where it divides in two lamina, the lower lamina over here, lower being the distal, and the upper lamina over here, upper being the most proximal. Now the upper lamina is also called the ulno-basal, and the lower lamina is also called the ulno-apical, attaching to the tip of the styloid. The gap in between is called the ligamentum subcreantum and is completely filled by vascularized connective tissue, and together with the vascular supply that is supplying the disc, the folded tissue has been termed as ligamentum subcreantum. The second type of insertion is a single broad insertion of the forms a triangular ligament or a proximal ligamentous complex. The blood supply, as mentioned, it's peripherally richly supplied thanks to the ulnar artery and its anastomosis with the dorsal branch of the anterior interosseous and the palmar branch of the anterior interosseous. As you can see here, the periphery 10 to 40% is usually the supplied ones, and center being the avascularized zone. Second most important structure is the radioulnar ligaments. It has two components, palmar and dorsal, each of these being divided further into two, that is deep and superficial parts. They originate from the radial bone and attach to the central portion of the TFC proper in the foveal region. Now, this is important, especially during the reconstruction phase, which Dr. Chetan will be talking about subsequently. These fibers are spirally oriented and in shape of a V. And these are the strongest of the ligaments that form the complex of the TFCC. Ulnomeniscal homologue is basically an atavistic remnant of the ulnotriquetral joint that still exists in several other primates. It is basically a fold of mucous synovial membrane. It merges from the tip of the ulnar styloid here, as shown by the yellow arrow, and it inserts on the ulnar side of the triquetrum and the lunate. Ulnar collateral ligament, it is serving as a reinforcement of the ulnar margin of the TFCC and the base and the body of the styloid process to the triquetrum and the pisiform. It has apneuritic extensions that goes into the TFC disc proper and also to the flexor carpi and the flexor retinaculum. Now, recently, some papers have stirred up a controversy saying whether the ulnar collateral ligament is just a thickening of the ulnar triquetral ligament or is a separate entity on itself. The ulnar triquetral ligament and the ulnar lunar ligament are both ligamentous structures that originate from the styloid on the palmar end and attaches itself to the lunate and the triquetrum. It functions as stabilizers of TFCC and serves as an enforcement to the joint capsule. Now, ECU tendon sheath and the tendon lies on the groove on the ulna, and it has a peculiar action during supination and pronation, which I will be mentioning subsequently in the respective slides, namely which the position of the ECU changes with the position of the wrist. Capsule, consider that as a bag that is enclosing the entire structure with the disc as a barrier that divides the bag into the upper radiocarpal and the lower radioulnar compartments. Certain pinhole defects are expected in this disc due to degenerative changes, not all of which are to be repaired or intervened on. Only the bidirectional defects are said to be pathological, that we will come to in that MRA section. Now, some of the anatomical variants after we've considered the normal structures. One is ulnar variance. How does this affect the TFCC? Ulnar variance depends on the center of the distal articular surface of the ulna and the radius in neutral position. Normally, which we see in a normal neutral variance is that either it is at the same level or the ulna is slightly below. The function on that is the TFCC thickness varies depending on the variance. Now, if the ulna is at the same level or slightly lower that we find in most individuals, the load carrying capacity, the load carrying responsibility for the ulna is only 20%. However, if there is a plus variance or a positive ulna variance, the ulna becomes longer. So in that, the axial loading on the ulna is seen to be double that found in normal situations. That is about 42%. So in that cases, accelerated degenerative condition like the ulnar impaction syndrome can be commonly seen due to the more rapid wear and tear and due to the excessive loads, double the normal load being borne by the TFCC. It is characterized by swelling, chronic and subacute pain, and motion limitation of the wrist. Coming to the functional anatomy, it acts as a primary stabilizer of the DRUJ and stabilizes the ulnar carpus during motion and distal radioulnar and distal radiocarpal joints. It acts as a shock absorption and provides a smooth surface for the carpal to glide on. Role of the TFCC in supination and pronation. As we all know, supination pronation, our total range of motion is approximately 175 degrees. The DRUJ acts as a pivot joint and with movements of the radius on top of the ulna. So the ulna remains static, the radius moves around it. So the radial portion of the dorsal radioulnar ligament and the proximal radioulnar ligament and the TFC disc, the radial half of it is commonly understood to be very rigid. They don't stretch, they don't extend. However, the ulnar half of it is what gives the freedom to move from pronation to supination. Radial attachment gives the rigidity and ulnar attachment gives the mobility. The proximal radioulnar ligament and palmar capsule are taut in supination. The dorsal radioulnar ligament and dorsal capsule are taut in pronation. Easy way to remember is when you're sitting, you look at the wrist, you see the palmar aspect when in supination. So the palmar ligaments are taut. Now pronate your wrist, you'll see the dorsal aspect. Now the dorsal ligaments are taut. That is one way to remember. And this is the principle that was explained by Nakamura, who described that in supination, the palmar structures are taut, and in pronation, the dorsal structures are taut. No differentiation was made by him in deep and superficial in this theory. Now, coming to evaluation, the most common mode of injury is forced ulnar deviation associated with a load compression. So an axial load with an ulnar deviated wrist. And it is more commonly seen in patients or individuals who have a intrinsic positive ulnar variance. The prevalence is about 49% in 70 years or older individuals and 27% in patients 30 years or older. But not all of these conditions are symptomatic. So we don't need to intervene in all of these structures if there is an incidental finding of perforation in the TFCC, unless symptomatic. Presentation, basically they come with an ulnar-sided wrist pain that worsens with activity, with grip weakness and instability, characterized by a clicking or joint tenderness in the space between the pisiform and the ulnar head. Commonly seen in racket sports, especially badminton players with a backhand grip, cricket, baseball, and also in daily wage laborers who have a heavy instrument like a hammer and repetitive hammering motion, or some individuals who have to carry a heavy load on a daily basis. Supination pronation weakness is also another characteristic feature of TFCC injury. Examination is best done with the wrist in pronated position, and to palpate for the TFCC, you have to palpate between the space of ulnar styloid and os pisiform and the FCU. Now, coming to examination, there are multiple tests of which I'll be talking about a few, but all of these tests on review showed that they have a good sensitivity, but the specificity is very low. So starting off with the first test, that's the TFCC compression test. You stabilize the wrist with one hand and you hold the patient's affected hand at the metacarpophalangeal joint, and you give it a ulnar deviation with an axial loading. Now, if the patient complains of pain that is reproduced with just like his normal symptoms, then it is considered a positive test. Like mentioned, these tests have a questionable clinical value. Next is the TFCC stress test. It's almost the same mechanism. You stabilize the wrist, you ulnar deviate the hand, and you give an axial loading. But at this time, you simultaneously palpate for the TFCC also. Third test is a supination test, where you ask the patient to supinate both his wrists and exert a upward motion, while at the same time, you will be resisting that motion. If there is pain on the ulnar side, on the dorsal aspect, due to loading of the dorsal aspect of the TFCC, it is considered to be a positive test. Another key test is piano key. In this, you pronate the hand, you stabilize it with the wrist in pronation. You hold the hand and stabilize at the level of the metacarpal phalangeal joints over here. And with the index and the middle finger, you give a dorsally directed downward force on the ulna, while at the same time with the thumb, you give an upward force from the volar aspect for the radius. Now, if it moves more than normal compared to the contralateral side, then it is considered to be a positive piano key test. Now, the reason why it's given this name is because it mimics the keys of the piano. It moves up and down just like the key of the piano. That is mainly attributed to the instability of the DRUJ due to the instability of the TFCC. Fifth test is the grind test. Caution to all, it is a provocative test, so use it as a last resort if at all. Stabilize the wrist, dorsiflex it, and apply an axial load. At the same time, rotate the wrist towards ulnar deviation. So stabilize, dorsiflex the hand, and give it an ulnar deviation. Rotate it towards ulnar, maintaining this constant force. Imaging and diagnosis. Step one, as usual, is basic X-rays. We cannot see the TFCC on X-rays. So what we are looking for is basically the variance. If there is a positive, neutral, or negative variance. If there is a fracture of the styloid in case of traumatic TFCC injuries. And if there is a DRUJ widening or instability. Second is MRA. Slightly controversial, but preferred over the conventional MRI or CT arthrography. The reason why it's preferred is because of its excellent intrinsic contrast resolution, early stage carpal instability diagnosis, and it differentiates TFCC tear types and helps us with the prognosis and management. So why is it controversial? Because we're giving a contrast into the joint, raising the possibility of infection, synovitis, and increased radiation exposure. And also it is time consuming. It is not routinely used, especially due to the cost factor and comfort issues. MRI, just like ramp lesions presented in the last week, diagnosis here is also a challenge. Sensitivity is high, but specificity is very low. Small size of the lesions, complex anatomy, the numerous number of structures, and the high signal to noise ratio is termed to be is given as the reasons for this challenge in diagnosis. However, due to the recent advances, especially during this drive procedure, that is driven equilibrium sequence or parallel imaging or 3D imaging, it helps to increase the specificity to a certain extent. Coming to the individual structures that we see in MRI, you can see the TFC disc proper with its two insertion. As we discussed in type 1 insertion, it will have an ulno-apical and an ulno-basal. And this white structure would be the ligamentum subcruentum. Here again, you can see it's a sequence of MRIs. It's starting off with the dorsal radioulnar ligament, you can see here. And coming slightly more forward, you can see the disc with the ulnar styloid and the meniscal homologue. And even more forward, you can see the volar radioulnar ligament. ECU appearance in the MRI axial view, you can see the ECU lying comfortably inside the notch over the ulna. However, as mentioned previously, when you supinate and pronate, ECU has a tendency to subluxate towards the dorsal aspect. For example, if you supinate your hand and dorsiflex with ulnar deviation, you can palpate your ECU over the ulnar head. At the same time, if you pronate it and dorsiflex your hand and ulnar deviate, you will not be able to palpate your ECU that easily. So that is what I mean by the ECU subluxation. So not all subluxation is pathological. When you supinate, a more than 2 mm of sagittal midline drawn through the center of the ulnar head on axial image, if it subluxates, that is considered to be pathological. Now the ulnar carpal ligament complex, that is basically the ulno-lunate, ulnar triquetral, and some studies even show an ulno-capitate. It rises from the palmar aspect of the PRUL, palmar radioulnar ligament, and attaches to the palmar aspect of their respective carpal bones. Macroscopically, it's very rarely distinguishable between the three. Now, coming to the interesting part, the arthroscopic diagnosis. So, hello? So, am I audible?
Yes, keep talking.
Oh, sorry. Now, just heads up to the fellows, I'll be asking a question to you in a couple of slides. So please pay attention. The reason why is because if you understand this concept, you're good to go, at least theoretically. So the concept I'm presenting here is a 3D 3-part concept. So think of the TFCC compartment as a room. Now to enter the room, you need a door. So the most commonly used door will be the 3-4 portal. What exactly is the 3-4 portal? It's a arthroscopic entry portal that is formed between the 3rd and the 4th extensor compartment. Now, once you enter this room, you see these structures. Confusing. So let's break it apart. So the 3 structures here. So let me orientate you first. You can see the distal radius with a sigmoid notch here. You can see the floor that will be occupied by the TFC disc. You can see the wall that will be the soft tissue components like the ulno-carpal ligaments, the ECU, the capsule. You can see the border between the floor and the wall that is formed by the radioulnar ligaments. Now the deep structures going and attaching to the fovea that is marked by the red over here, and the superficial structures going and attaching to the styloid. So the roof of this room will be formed by the medial proximal row, which is distracted using finger traps. Now, once we've understood the basic concepts, now let's assemble it back again. Now the roof, again, the medial proximal row distracted with finger traps. The floor is the TFC proper. The wall is the ulnocarpal ligaments, the ulnar-lunate, the ulnar-triquetral, the ulnar-collateral, meniscal homologue, and the ECU. The border between the two are the radio-ulnar ligaments. So once you understand this concept, at least you're good enough to orient yourself to diagnosticoscopy as at least. Not that easy, but then you understand the concept. So the question I want to ask is, anyone would like to have a go at this? Identify the different structures?
Yeah, one of the fellows can answer, no?
What's my left side will be the ulnar-lunate ligament. Next will be ulnar-triquetral. The posterior part is ulnar-capitate, and this yellow and orange are the radio-ulnar ligaments. Red is the foveal point of the ulna. This blue shaded area is fovea, and the tendon on the right side of the picture is ECU.
So that is those are the structures that we have encountered, and the blue being the disc and the red being the fovea. So now we've come across the normal. Let's go to the pathologies. So how does the arthroscopic diagnostic arthroscopy help? First, in case of RUL reins, the radio-ulnar ligament injuries. So first is foveal radio-ulnar ligament avulsions. You can see the posteromedial bony avulsion of the dorsal radio-ulnar ligament. You can see the anteromedial bony avulsion of the volar radio-ulnar ligament. And you can see the complete radio-ulnar ligament avulsion from the sigmoid notch itself. Next, you can also see the lesions on the capsular wall. The first image showing the dorsal TFCC detachment, the volar TFCC detachment, and a linear tear of the ulnocarpal ligaments, or avulsion of the ulnocarpal ligaments from the medial proximal row in entirety. Another thing that we can observe is any lesions, traumatic or degenerative, in the TFC disc proper. So in case of traumatic, there will be central perforations, which we can examine, or in degenerative conditions, you can see multiple pinholes, degenerative disc proper tears, which will help us in classifying and planning management and prognosis. Coming to classification, it was proposed by Dr. Palmer et al. And it was classified in two major groups, traumatic and degenerative. Now, reading this from this list will be slightly difficult. So let's go over each and every one of them with figures. So type 1A will be a central perforation, as you can see here. And you can see in the MRI also here. 1B will be an ulnar avulsion with or without a styloid fracture. This is a styloid fracture. And this is the one without a styloid fracture, but then there is an ulnar avulsion. 1C will be a distal avulsion of the attachments involving the ulnar-lunate or the ulnar-triquetral. You can see there is a signal intensity at the ulnar-triquetral in this ulnar-triquetral. And you can see a small tear in the attachment of the TFC disc proper also. Now, type 1D will be a radial avulsion of the TFC disc proper with or without a sigmoid notch fracture. You can see a complete avulsion here. So that's type D. Coming to the degenerative aspect, first 2A would be a wear or a thinning or a fraying of the TFC disc proper, but without a perforation. That is the keyword. 2B will be a 2A with lunate, triquetral, or ulnar chondromalacia. So you can, if any of these bones have chondromalacia in addition to the degenerative tear, degenerative fraying, then we classify it as a 2B. 2C, again, that's one step more. That fraying and thinning will result in a perforation along with the chondromalacia of the lunate or the triquetral. 2D will be a lunar-triquetral ligament perforation with any of those above mentioned conditions, if it's a fraying or if it's a perforation or if it's a chondromalacia that is mentioned above. The thick arrow here shows the perforation of the central disc. The thin arrow has the chondromalacia, if you can observe here. And the arrow head will show the small and regular lunotriquetral ligament over here. So in order to summarize, just to recollect, we've gone through the anatomy, the different structures in individual, giving individual merit to the same. We've evaluated the condition. We've understood how they present and how we examine with the tests. We've gone through the imaging and diagnosis with the skygrams for variance, fractures, and DRUJ instability widening. We've gone through MRI or MRA, and we've gone through the arthroscopic portal examination, at least in the diagnostic point of view. And we've gone through classification. So I would like to end my presentation here. Thank you, everyone.
Thank you, Ashik. We can go to the next presentation and then we'll have discussion later.
Sure. I'm done.
Good morning, sir. Is my screen visible and am I audible, sir?
Yes, Jason. Proceed.
Good morning, sir. I'll be talking about management of TFCC injuries. So the anatomy has been very broadly described by Ashik. So this is the anatomy which we are focusing mainly upon. So clinical presentation, it is associated with activity-related ulnar-sided wrist pain, which involves the movement of the wrist, like rotating the doorknobs or opening the lid of the jar or a bottle. And also it is associated with weakness in the grip, instability, or clicking at presentation. And another thing is difficulty in supination and pronation when it is associated with DRUJ instabilities. So all these provocative tests and all has been described by Ashik. So this is an ulna-fovea sign. It is a point between pisiform FCU tendon and distal ulna. So Tay et al. Described that this test, if it is positive, has high sensitivity and specificity. And also it denotes that there might be an association of ulno-triquetral ligament and disruption of foveal attachment of the TFCC. This is TFCC compression test. The picture here is self-explanatory and has been explained clearly in the previous presentation. This is the piano key sign where there is loss of volar resistance on applying the pressure on the prominent ulnar styloid process. This assesses the stability of DRUJ. This is the Bellotment test where it involves anteroposterior and posterior anterior translation of the ulna on the radius and a neutrally rotated forearm. And if it is positive, it represents complete disruption of TFCC. It's the grind test. So evaluation is by radiograph to assess fracture and ulnar variance. This is the positive ulnar variance and MR arthrography. So Bohr et al. In 2018 conducted a study and they concluded that MR arthrography is just slightly more accurate than conventional MRI, considering the cost factor, the investigation being invasive and time consuming, and hence a non-contrast MRI is usually sufficient to detect TFCC tear. Onsen et al. Found that sensitivity and specificity of MRI for radial side was closely approximating around 100%, but it was not so for the ulnar-sided tear. So, and they concluded that low-grade MRI will not be able to diagnose the ulnar-sided tears. So in this image, you can see where the signal to noise ratio and resolution is less on the left side of the picture, and whereas in the right side of the picture, it is more clearer. So when we go for 3 Tesla MRI, it can pick up most of the tears. And as we all know, arthroscopy is the most accurate means to diagnose TFCC injury, irrespective of the location. So this is the normal anatomy and normal TFCC structure on an MRI. So this is one more test which is done intraoperatively is trampoline test, where a probe is inserted and a pressure is applied on the TFCC, and that rebound ability of the TFCC determines whether the TFCC is intact or it has been torn peripherally. So here the pressure is applied, and we can actually see the indentation of the probe in this figure. And this, if this indentation is positive, this denotes positive trampoline test. Hook test also done intraoperatively, where the probe is inserted in the 6R portal and it is passed beneath the foveal region of the ulna. So here in this picture, we can actually see the profile of the probe, and once inserted, it is lifted laterally and upwards. And if the TFCC is lifting along with the probe, it denotes the detachment of the insertion of the TFCC. So this is the paper by Adzi et al. In June 2021, where they concluded that hook test is more accurate than trampoline to detect foveal tears. It also concluded DRUJ arthroscopy is not necessary to confirm foveal incompetence of the TFCC if this test is positive, hook test is positive. Coming to classification, it is Palmer's classification, and it is broadly divided into type 1 and 2, 1 being traumatic, 2 being degenerative. 1 is the commonest types of tears and are located central in the fibrocartilaginous disc. And these lesions usually do not cause any DRUJ instabilities. Type 1B, this subgroup represent traumatic peripheral tears of TFCC from its ulnar insertion. These injuries are either due to soft tissue avulsion of ligaments from the fovea or bony fractures of the ulnar styloid base. And hence it is associated with the instability of DRUJ, and careful evaluation is mandated. And these injuries are more amenable to repair as blood supply is good at the periphery. So this is type 1A and 1B. As it is located towards the periphery, healing is very good. So this is the MRI image. This is type 1, type 1A, whereas it is a central tear, and this is ulnar side foveal tear of the TFCC. Type 1C, these are uncommon injuries associated with high energy velocities that involve the injury to ulnotriquetrate and ulnolunate ligament, and also ulnocapitate ligaments. These ligaments usually, this is the location of 1C. These ligaments usually resist disruption due to their good strength, and hence high velocity RTA or fall from significant height necessitates its injury. And hence these are usually associated with DRUJ instability as well as gross ulnocarpal and intercarpal dissociative instabilities. So this is an MRI image showing tear of the ulnotriquetral ligament. 1D, these are avulsion injuries from sigmoid notch of the radius, and cause disruption of the insertion of dorsal and palmar radioulnar ligaments. And because of the injury nature, DRUJ is also associated with this 1D. So this is the radial sided avulsion, and this is classified as 1D according to Palmer. Type 2 are the degenerative tears due to abnormal loading of ulnar side of the wrist representing the ulnar impaction syndrome. Ulnar impaction syndrome, they are indirectly referring to the positive ulnar variants. Summarizing, it is type 1 we have discussed in detail. Type 2 is degenerative. 2A is TFCC wear. 2B is TFCC wear with ulnar or lunate chondromalacia. 2C is TFCC perforation with ulnar or lunate chondromalacia. 2D is 2C, 2C with lunotriquetral ligament perforation. 2E is 2D plus ulnocarpal arthritis. So 2A, this is TFCC being thinned out. 2B, TFCC being thinned out with lunate chondromalacia. And this is TFCC perforation. Perforation starts from 2C onwards. So 2D is associated with lunate chondromalacia and lunotriquetral ligament tear. 2E, it's a complex tear along with ulnocarpal arthritis. So Atsi et al. Came up with a new classification where it is mainly focused on treatment. So algorithm of treatment according to Atsi classification is based on clinical assessment of DRUJ instability by Bellotman test, then radiographical presence of the styloid fracture, whether either it is tip or basilar, and evaluation by arthroscopy, both the radiocarpal and DRUJ. So summarized Atsi classification here. So it is 0, 1, 2, 3, 3A, 4, and 5. So let's concentrate on this picture. So type 1 is ulnar styloid tip fracture. So there is no disturbance in DRUJ and hence it's stable. TFCC is also not involved. Hook test will obviously be negative and treatment is by immobilization. Type 1, here distal TFCC tear. So DRUJ is definitely not involved and hence stable. Distal is torn, proximal is intact. So this is treated by TFCC suture repair. Type 2, it is both distal and proximal tear. So this causes mild to severe instability of the DRUJ. Both the limbs of TFCC are torn and hook test will be positive. So treatment is aimed towards fixation of this proximal TFCC to fovea. So type 3 is proximal TFCC tear. Clinical features and treatment is almost same as type 2, and treatment involves fixation of proximal TFCC to the ulnar fovea. So type 3A, this is ulnar styloid base fracture. So DRUJ instability will not be there, and distal TFCC and proximal are intact. So hook test can be positive depending upon the extent of the involvement of this fracture and extending into TFCC. Treatment is fixation of this ulnar styloid fragment. Type 4 is irreparable TFCC tear, and treatment is by TFCC reconstruction. Type 5 is DRUJ arthritis, and treatment is by salvage procedures. So this is Atsi classification. So treatment. This is an article published by Jawad et al. Published in Clinical Orthopedics and Trauma in 2020. This is the paper by Ames Delhi, and their management is based on the Palmer classification. So initial treatment of all types of TFCC injury includes a rest in the sense complete abstinence of sports or activity modification, sprints or cast, physical therapy, cold packs, and NSAIDs. So in recalcitrant cases, corticosteroid injection or PRP can also be tried. Physical therapy to prevent stiffness and gain the motion is instituted once discomfort due to acute trauma or inflammation has been subsided. Strengthening exercise usually is begun after 6 weeks of recovery. Surgical management, type 1A tears that do not respond to conservative trial are the lesions managed with arthroscopic debridement. They form unstable flaps and hence they have complaints similar to locking caused by the meniscal tear of the knee. Because of the tear, there is synovitis and hence pain. Aim of debridement is to shave off all the loose flaps and create stable rim of TFCC similar to meniscal debridement and partial meniscectomy. Adams et al. In their study concluded that up to 80% of this substance can be removed without creating any iatrogenic instability. technique of arthroscopic debridement. So examination of articular distension and reboundability, which has been already described as trampoline test, is performed, and any laxity should alert there is detachment at one or more sites, and hook test is also done to evaluate the foveal insertion of deep fibers of radioulnar ligaments. So type 1B, this is the treatment of type 1B. The treatment, this is the type where a lot of studies have been conducted towards refinement of the treatment, because these being very vascular are amenable to successful repair and healing. Partial tears of 1B usually do not involve radioulnar ligament injury and are stable and are treated by capsular repair. So if a TFCC is avulsed from the foveal insertion, reattachment to refix the foveal insertion is done to restore the de-erosion stability and function. If for chronic and massively retracted tears, tendon graft is required. A brief technique of open repair. In curvilinear incision is made. The extensor retinaculum along the EDM is retracted, is severe, and the EDM is retracted downwards. Rectangular based ulnar based flap is created, protecting the dorsal radioulnar ligaments. Attachment of TFCC is evaluated, curated at the fovea, and a small anchor with 2-0 suture is inserted. One limb is then passed lateral to the tear, piercing the dorsal ligament, and the knot is tied inside the joint. The technique of arthroscopic repair, this is termed as capsular repair. So initially diagnostic arthroscopy done with small arthroscope, 30 degree with the standard 3, 4, 4, 5 portal. Trampoline and hook tests are performed. Scar tissue from the margin is cleared. Important thing to be noted here is to protect the branch of dorsal sensory branch of ulnar nerve. So the scar tissue and the frayed margins are debrided. Then 2-0 suture is passed into the joint and it is taken out through the 4-5 portal. And a second needle with the loop of proline is directed laterally and also retracted out of the joint through 4-5 portal. And the first suture is shuttled into the loop of the proline suture and withdrawn, creating the horizontal mattress with a modified Mason-Allen suture configuration. So foveal detachment, arthroscopic foveal reattachment using transversus canal. Allotment is done as a rule. Routine arthroscopy is done under vertical traction. Trampoline and hook test is done. Next, a transosseous tunnel is drilled with 1.6 mm K-wire with foramen in neutral position. So targeting a device like this can also be used. And the fiber wire is passed into the tunnel and through the TFCC, and the rest of the repair procedure is similar as for the capsular repair. After the sutures have been passed, traction is released and maintaining the de-erosion reduction and neutral rotation of foramen. Knots are tried. Hook test is performed again to check the integrity of the TFCC, whether it has been well reduced and compressed onto its footprint. And above elbow slab is applied in neutral foramen rotation. So this is the paper published in November 21 by Tinge et al., where they describe the procedure where to repair for the irreparable TFCC tears. So they used palmaris longus tendon. The graft is harvested and it is shuttled through the radius, just 5 mm lateral to the sigmoid notch. So the foveal region is debrided thoroughly, and this is the guide. So transosseous canal through the to the fovea through ulna is created, and both the limbs, once we have passed through this hole in the radius, both the limbs are retrieved into the joint, and it is shuttled into the transosseous ulnar tunnel created using the guide. And once we reconstruct the TFCC, this is the pictorial representation of the repaired TFCC. And this is the orthoscopic image where we can clearly see the dorsal and volar limbs of the TFCC. Type C, 1C and 1D, these two subclasses can also be treated by orthoscopic repair, but less studies have been conducted, being the injury being very rare. And modified technique of open repair of 1D tears has been described by Kuni and colleagues. Management of type 2 tears, type 2A, 2B, 2C are initially treated conservatively. And if it is unsuccessful, then a wafer procedure can be performed. 2D lesions can be treated with the ulnar shaft shortening with osteotomy. 2D lesions are treated by resection of ulnar head. So 2D is ulnar and lunate chondromalacia with lunotriquetral ligament tear. 2E is ulnocarpal arthritis, and it is treated by resection of ulnar head. So a brief note on wafer procedure. Rule of orthoscopy holds good, and standard protocols are established. Debridement of scapholunate ligament and also lunotriquetral ligament is done if necessary. Large portion of disc is excised, and the large portion of the disc is excised and the ulnar cartilage exposed. And the ulnar cartilage is drilled using the burr, starting from the ulnar side and progressing towards the radial side. And some 2 mm of subchondral bone is also taken off. While doing this procedure, there is chance of breaching the radial and volar radioulnar ligaments, and it has to be taken care of because it leads to DRH instability. Coming to complications, post-operative complications include infection, hypertrophic scar, tendon injury, nerve injury, RST, and joint stiffness. Another major risk is, as we just discussed, it is iatrogenic instability following aggressive debridement. And the rule to be followed is to avoid violating 3 important anatomical regions, that is the fovea, sigmoid notch, and the D fibers of the radial ligaments, to prevent this iatrogenic injury followed by the Wafers procedure. And serious complication, which has been always emphasized, is the injury to dorsal sensory branch of ulnar nerve. So take-home message is, the TFCC tears are a common cause of ulnar-sided wrist pain with varying degree of DRH instability. Clinical examination with MRI, formatted diagnosis and treatment plan. Acute tears can be managed conservatively, and if there is no instability, chronic tears can result from previous trauma causing disturbance in ulnar variants. Arthroscopic techniques have evolved over past 2 decades and can be used as a gold standard for evaluating and classifying and treating the TFCC injury. And the procedures are arthroscopic debridement, capsular repair, transosseous repair, or a wafer procedure. Thank you, sir.
Yeah, thank you, Chetan. This was a very good presentation by both Ashik and Chetan, because you made us understand concept which is difficult to understand in a very easy manner. So this is how we have to do a presentation, especially that arthroscopic orientation picture for TFCC was the best. So in future, other fellows, anything with respect to arthroscopy, get those kind of pictures and try to explain better. See, as I told you, the TFCC is very commonest wrist arthroscopy condition we usually come across. And as a young surgeon, we may be inclined towards fixing the TFCC tear when we come across in our practice because we want to do wrist arthroscopy. So that is not the right way. Always supplement your MRI-based diagnosis with your clinical diagnosis, because many a times the TFCC tear can be mimicked by an ECU tendinitis. And most of the TFCC tears, which is usually a foveal detachment, has a very good potential to heal on its own if you immobilize and conservatively treat it for a period of 3 months. So always keep in mind, failure in the conservative treatment is the indication for surgery. and associated distal radial ulnar joint disruption. That shows the severity of the injury. If the patient has just got a tenderness in the TFCC area without any other sign positive, then conservative is the line of management. And this is most commonly seen in people who are involved in sports, which causes excessive rotational movement in confined to the wrist, especially badminton, tennis, and usually the table tennis as well. So there is a lot of ulnar-sided deviation of the wrist with your strokes. So we have to be very cautious while dealing with those kind of patients, and we have to get them back to sporting activities. One example is which we had recently, a twin around 12 years old. Twins were involved in badminton. They are into professional badminton, and one of the twin had ulnar-sided TFCC injury, which was appropriately maintained or treated with conservative line like immobilization, and also change in the racket, because she was using a very large racket with a big handle, which was causing significant impingement of the ulnocarpal area. That was a main culprit resulting in the TFCC injury. So you have to identify the cause and treat appropriately, which will definitely be successful. And as far as surgery is concerned, it is not mandatory that all the TFCC tears need to be operated arthroscopically. Okay, because doing an arthroscopic TFCC repair is not an easy job. If you are comfortable opening up, visualizing the tear and repairing it appropriately, that itself is a good procedure. But the only problem is the presence of a hypertrophic scar, which will mimic the TFCC tear. So be careful with the scar formation and prognostic of the patient, and appropriate immobilization and rehabilitation following a well-done open TFCC repair is as good as an arthroscopic TFCC repair. So clinical history, the mode of injury is very important. Supplement it with an appropriate clinical investigation, clinical examination. MRI scan will always show a hyperintensity in the foveal region in case of a sprain, which can be mistaken for a tear. So always discuss with your radiologist regarding the severity of injury, whether it's a tear or a sprain, and then proceed if the conservative line fails.
Yes, sir. Thank you.
Sir, morning, sir. Praveen, sir. Sir, immobilized for how long, sir? Just
6 weeks.
6 weeks, sir.
Yes.
Okay.
It depends. It depends, because see, the thing is 6 weeks of immobilization and assess the patient's pain scale, and the patient's pain scale significantly reduces, then you can start with gentle rehabilitation. But ideally, the literature says you wait for 3 months. If the 3 months of immobilization does not improve the patient's condition, then definitely a steroid injection can be done. Steroid or PRP can be done with variable outcomes, but it can be tried prior to surgery. And even that fails, yes, we have to fix it up. But it is different to different type of tests. See, if it's a very small detachment in the foveal area, yes, conservative line of management. If it is a complete detachment along with the ulnar styloid disruption, then it's highly unlikely to unite, and you may have to go and fix it.
Okay, sir. So then timing of MRI, sir, like say acute tear, is this going to immobilize for
acute tear is actually better, because the hematoma itself acts as a medium to further separate the TFCC from the bone if it's a foveal detachment. There's nothing wrong in going for MRI scan, provided your clinical examination is suspicious, because see, there is an overlap. ECU tendinitis is most important culprit, which will mimic TFCC tear. So always check for the piano key sign, which indicates a DRUJ disruption, and the stress test, the ulnar deviation and compression, that will actually provocate the TFCC tear. So if these two are positive, then you have to go for MRI scan.
Okay, sir. Thank you, sir.
Sir, if you're planning to manage conservatively, what sort of immobilization we should give, sir?
I mean, different school of thoughts, either pronation or supination, depending upon the DRUJ stability. Okay, always assess the stability. Whichever position, that is in pronation to supination or mid pronation, where the DRUJ is stable, you have to immobilize it. If the patient's DRUJ is intact and still the patient has got a TFCC injury, just a below elbow cast application to prevent the radial and ulnar deviation of the wrist.
Okay. Thank you.
Shyam,
And
good
sir,
summarizing. Go on.
Sir, what determines whether the fixation of ulnar styloid fractures? When do we have to fix them? Is there a
I
criteria?
have never. I mean, see, it depends upon the size of the fragment and the ulnar styloid fragment fixation mainly depends upon the anatomy of the distal radius fracture. See, if the distal radius fracture is so severe that it is meant to collapse, okay, when it is meant to collapse, and it will result in a union of the distal radius, but with a positive ulnar variance, then it's mandatory that we may have to use the ulnar hook plate and fix the ulnar styloid. But as a school of thought, what I try to do is I always try to maintain the radial length and inclination as much as possible, which means I try to make sure that the radial styloid becomes congruous with the distal radius, even if the lunate facet is unstable. So by maintaining the length and the inclination, the anatomic tensile strength of the radio-ulnar and the radiocarpal ligaments are maintained. So this will prevent any TFCC injury in future or ulnar variance in future.
Thank you, sir.
Good presentation. Good summarizing, Shyam. And maybe I missed it. Is there any kind of tear that you see in the beginning itself? You say that this has to go in for fixation, and this you don't have to. Like, for example, positive tear with positive ulnar variance, and I don't know whether you got my. Is there any particular tear
Understood,
which
sir.
has to go for surgery straight away?
Sir, acute tears have got a very good potential to heal very well. It's
all kind.
Yes, sir. Unless and until the patient has got a distal radial joint disruption. So all the mostly, see, this is a very vascular area. So always nature has its own potential to heal, provided we immobilize it at the right time. Now, if the patient has not undergone a conservative treatment and come to us more than 3 months later with a fresh complaint of TFCC injury, then I think we have lost the essential time for a good vascularity to heal the tear. And that is when we advise, okay, go ahead with the fixation, because the initial period of immobilization is the one which restores the congruity of the ligaments and ensures the vascularity. If that is lost because of the distal radial joint disruption or movement, then the natural healing is still doubtful. So in that case, we may have to go for surgery. If a patient comes with history of fall yesterday and today we are doing an MRI scan and showing a TFCC tear, no need to operate. We still have a good potential to immobilize it and treat it conservatively. Rather, if the patient had fallen 3 months ago, has not immobilized the wrist, and now he comes with a pain and it shows a foveal detachment, then it is less likely for the tear to heal, and then I may be inclined towards fixing that tear.
Thank you. Good message. Thank you.
If you don't have any questions, we can proceed to the next topic. Thank you.
Good morning, sir. Am I audible, sir?
Yes, Rishabh, you're audible.
Good morning, sir. Today I'll be presenting a topic on Atlantoaxial instability, sir. Coming to introduction, Atlantoaxial joint is the most mobile joint with several neuromuscular structures traversing through it. It mainly comprises atlas, the C1 vertebra, and the axis C2 vertebra. The complex transitional structure mainly bridges the occiput and the cervical spine. Functionally, the atlantoaxial joint provides support for the occiput, and it has the greatest range of motion and flexibility while maintaining stability at the whole spine. Coming to anatomy of the joint, coming to C1 vertebra as such, it's a ring-shaped structure which is devoid of the vertebral body. It contains mainly an anterior arch and a posterior arch, which is bridged by two lateral masses. These lateral masses contain superior and inferior articular surfaces. Articulation, the superior articular facet actually superiorly articulates with the occipital condyles, and inferiorly it articulates with the axis. Posteriorly to the anterior arch is the odontoid process of the axis. The joint surfaces of the atlantoaxial joint is almost parallel and flat. In sagittal surface, it's more or less horizontal, and in coronal plane, it's mediolaterally sloping. So this actually provides the joint with unrestricted movements in different planes. Basically, there are 6 degrees of movements happening at this joint. The angular motions, which mainly involve the flexion extension, the rotation movements where the rightward turning and the leftward turning, and linear motion and translation are the other 2 movements. Atlantoaxial joint is an osteoligamentous joint. The main ligaments form the basis for the stability of this joint. Cruciate ligaments form the most important ligament, which mainly includes the transverse axial ligament and the vertical ligaments. The transverse axial ligament is runs through the lateral masses of the two lateral masses of the C1 vertebra. It covers the dens anteriorly. Additional support is also paired by the alar ligaments and the apical ligaments. The alar ligaments attach the tip of the odontoid to the base of the skull. The anterior longitudinal ligament with rostral extension of posterior longitudinal ligament along with facet joint capsules and the posterior myoligamentous complex completely form the cohesive occipito-atlantoaxial junction. Now, coming to classification, atlantoaxial instability can be classified as traumatic, congenital, and inflammatory. Traumatic usually occurs in sports injuries, especially in football and rugby sports. It mainly results from a disruption of the transverse axial ligament. Without any risk factors, this traumatic instability is quite rare. And the most odontoid fracture, especially type 2 odontoid fracture, is the main cause for the traumatic instability. Coming to congenital, various congenital syndromes like the Down syndrome, which is being the most common, has the congenital instability. Then followed by skeletal dysplasias and spondyloepiphyseal dysplasias also are the few causes of congenital instability. Coming to inflammatory causes, RA is the most common cause. Rheumatoid arthritis is the most common cause of atlantoaxial instability. According to literature, rheumatoid arthritis has an incidence of 23 to ranging from 23 to 86% of incidence of having atlantoaxial instability. Since the atlantoaxial joint is a synovial joint and most of the ligaments are covered with synovium, there is a high prone chance of rheumatoid arthritis having the atlantoaxial instability. Coming to signs and symptoms, atlantoaxial instability can present with varied spectrum of clinical signs, but more or less mostly they are asymptomatic. Patient may present with neck pain with restricted range of movements. There may be pyramidal signs or myelopathy signs. Lower cranial pulses may be also a few presentation. Patient may present with a respiratory failure. There may be vertebral artery dissection and may come with quadriplegia. And in the rarest of cases, they may present with death. Coming to evaluation and diagnosis, a study conducted by the Moore et al., the National Emergency X-ray Radiography Utilization Study. The following X-ray views were suggested to be taken, which mainly included open mouth odontoid view, anteroposterior view, and a cross-table lateral view. The alignment of the facets in the lateral view with the head in neutral position was the mainstay in categorizing the variants of atlantoaxial joint instability. CT scan has a higher specificity. Coming to few definition, the atlanto-dense interval. It's a small slit-like space between the posterior aspect of the atlas ring and the anterior part of the odontoid process. It's measured from the anterior border of the axis to the anterior arch of the atlas. In this image, the first image is the lateral view in a neutral position, and when you see the extension view followed by extension view and the flexion view, there is a translation of there is an increase in the atlanto-dense interval, which shows there is the atlantoaxial instability. Atlanto-dense interval is normally a constant during movements of the head. Usually, the translation is less than 3 mm in adults, and it's less than 5 mm in children. The most common subluxation will be the anterior subluxation. Anterior subluxation causes decrease in the space available for the cord. It increases the risk of spinal cord compression and also the neurological sequelae. Coming to one more, space available for the cord. It's also called as the posterior Atlanta-dense interval. It's measured from the posterior surface of the dens to the anterior surface of the posterior arch of the atlas. The normal space available is actually 17 mm, plus or minus 1.2 mm according to the literature. Less than 14 mm predicts the development of paralysis. Now, coming to criteria for atlantoaxial instabilities, the following criteria were set as told for this thing. That is atlanto-dense interval, which is more than 5 mm. There is overriding of anterior arch of atlas on the odontoid. Space available for the cord if it's less than 13 mm. Translation of the tip of the odontoid tip more than 4 mm of the basion, and a violation of Steele's rule of thumb, which is actually 1/3 cord and 1/3 odontoid and 1/3 space available in the C1 C2 ring. Coming to the types of atlantoaxial instability, Greenberg in his study actually classified atlantoaxial instability into two types, reducible and irreducible. He also devised the treatment aspect where irreducible atlantoaxial instability would require immediate decompression and active stabilization. Further, Fielding and Hawkins classified the atlantoaxial instability based on the direction of the dislocations. He mainly classified into anterior, posterior, lateral, and rotational type. This is widely accepted for the clinical application of the variants of the atlantoaxial instability. Wang et al. Taking further into Greenberg's classification, Wang et al. Classified the atlantoaxial instability into 4 main types. The type 1 included only instability. Type 2 included reducible instability. Type 3 included irreducible instability, and type 4 included bony dislocation. He also suggested the treatments for the particular type of instability based on the reducibility or irreducibility of that atlantoaxial joint. Based on the radiography, based on the alignments of the facets on the lateral imaging with a head kept in neutral, again 3 types of atlantoaxial instability were described. The type 1 included the facets of the atlas dislocated anterior to the axis, and type 2 included facets of the atlas dislocated posteriorly to the axis with rotatory dislocation, and type 3 included though the facets are aligned, the instability is confirmed by clinical or radiological clues. Type 2 and type 3 are chronic instability, and these are also called as axial or central axial atlantoaxial instabilities. This is one test described in literature for demonstrating cervical instability called as Sharp-Purser test. Here in the initial image, the neck, the examiner holds the neck in a slight flexion and keep his thumb on the spinous process of the axis, with the other hand keeping on the head. Then he gives, in the second image, he gives a dorsal pressure on the head and exerts pressure posterior behind. A positive test is a feeling of head sliding backwards during the movement. This test actually assesses the integrity of the transverse ligament. This test should be performed with extreme caution. Coming to treatment aspects, non-operative line of management, the cervical halter traction in supine position and active range of motion exercises for the first 24 to 48 hours first, and then it is followed by with active ambulatory orthotic immobilization with active ROM exercises until free motion returns. Non-operative treatment is mainly indicated for children who present with acute transverse ligament injury without any neurological deficits, and patients with Grissel syndrome. Grissel syndrome is a laxity of the transverse axial ligament which occurs due to a infection. These patients are known to heal normally, so a conservative line of management can be tried in these syndromic patients. Coming for the indications of surgery, for adults, if atlantodense interval is more than 5 mm and any instability in the dynamic views forms the indications. And for children, neurological deficits, persisting atlantodense interval for more than 4 mm and persisting deformity more than 3 months. Recurrence of deformity even after 6 weeks of immobilization forms these indications for surgery. Skeletal traction under general anesthesia is initially advised. Traction weights are started with 7 to 8% of the body weight to a maximum of 7 kgs. Traction mainly involves 3 phases. Image A shows the initial distraction phase, where the head is kept in the slight flexion with the C1 ring opposing to the odontoid, so that it avoids hitting the spinal cord during the traction maneuver. The second image shows the realignment phase, where the C1 vertebra slips back over the odontoid, and the third image shows the reverse reface phase, where there is slow extension of the head, allowing slowly releasing of traction over several hours with decreasing the weights. Here, serial lateral imaging has to be taken, and subsequently in the lateral images will show a decrease in the atlantodense interval. Now, coming to procedures, decompression alone is recommended when it is reducible type. Anterior approach is also required when the dislocation is irreducible. Anterior approach mainly includes the transoral odontoidectomy, transoral anterior release, or transoral anterior reduction plate. Good anatomic reduction and improved neurological improvements have been seen in these procedures. Coming to posterior orthodosis, Gales and Sonotong or Brooks methods have been used, where wires alongside with bone grafts are used for the complete fusion of the C1 C2 vertebra. These procedures actually require prolonged immobilization. There is high risk of complication and risk of non-union also. There is a high graft site complications occurring with these procedures. Transarticular C1 C2 Megrel type, or C1 lateral mass to C2 pedicle screw goal hormones, or C1 pedicle to C2 pedicle implants have been used. These can be applied to children as young as 2 years of age. These form the solid construct with high fusion rates. There is a significant stabilization in all axes of rotation. Now, accurate screw positioning and avoiding injury to the vertebral artery through spinal navigation is possible. Then coming to the occipito-cervical fusion. Occipito-cervical fusion is mainly for the occipito-cervical instability with concomitant basilar invagination. Whenever there is osseous anomaly of C1 vertebra, and it usually is done when there is a failed previous atlantoaxial fusions are there. This procedure actually post-procedure patient will be having a restriction of head movements. Coming to complications of the surgeries, the main complications being the graft subsidence, instability of subaxial spine, and after fusion, the cervical lordosis is known to increase with 1 degree per fuse level till adulthood. The subaxial kyphosis usually corrects itself via Toyama remodeling. Other than these complications, the operative complications like vertebral artery injury or spinal cord injury, infection, and donor site morbidity forms the other complications. Coming to the prognosis, symptomatic patients improve with surgical management. Mainly relieves the pain and decreases the myelopathy signs and symptoms. Single breath count of less than 10 and single breath hold of less than 10 seconds are major determinants of morbidity and mortality in congenital atlantoaxial instability. With the advent of spinal navigation surgery, the surgeries can be performed with much precision without injuring the major structures. Coming to conclusion, sir, atlantoaxial injury can present in varied age groups from children to adults. Patients with long-standing rheumatoid arthritis presenting with neck pain should rule out atlantoaxial instability. Patients with congenital syndrome should have been evaluated with dynamic X-rays and a yearly MRI to know any cord compression or a decrease in the space available for the cord. Before any initiating physical activity, a thorough neurological examination is recommended to see for any deficits, and initiating premature exercise can lead to quadriplegia or paraplegia. Thank you, sir.
So usually you have given a good overview. Have you also read about the rotatory atlantoaxial subluxation in children?
Yes, sir. Actually,
that's a totally different entity from this atlantoaxial subluxation that you're talking about.
Okay.
There are 4 types. You also need to read about that, because children usually present with something called the rotatory atlantoaxial subluxation, which is not anteroposterior, but the atlantoaxial joint rotates over the atlas rotates over the axis.
Yes, sir.
So
okay.
Go through that also. There is a classification for, and you don't need to know all the classification systems. Wang is what is used nowadays. So
Yes.
wherever you are quoting, you can use the Wang classification. That is enough. And you have not spoken anything about this thing about the braces.
Cervical halter brace only.
Yeah, once you have reduced it, you can't leave it like that. So once you have reduced it, you have to put them on brace.
Okay, sir.
So there's a bracing system. Usually what we use is a SOMI. So also need to read about the SOMI brace and all. Okay. And there is something called halo vest. In certain cases, we may have to go for a halo vest when it is really unstable and the patient cannot be taken up for surgery. Okay. These are all theoretical parts only, but still you need to know when a case is kept.
Okay.
Otherwise, this is reasonably okay. And next class, maybe you can present on the rheumatoid arthritis, the effects of rheumatoid arthritis in cervical spine, where you have the 3 atlantoaxial, you have the basilar invagination, and you have the subaxial subluxations.
Yeah, okay, sir.
Sriram, I think it's a good idea. Why
Sir.
don't you invite the rheumatologists in and around Coimbatore also for the Zoom meeting?
Okay, sir.
Try to involve them.
Okay, sir.
Thank you.
Thank you, sir. Sham, we have done.
I can close the meeting if it's all over. Thank you.
Thank you.
Gopal, are you there? Good night. Yes, Adosh, she can conclude it.
Yeah, okay, sir. We'll end the meeting.
Yeah.
Thank you.